And just across our borders to neighboring Uganda, where the country has confirmed its first positive case of the coronavirus. The country has since moved in to impose stringent measures to stop the spread of the disease, including the close of its borders. Now, other countries in the region, including Rwanda, have imposed lockdowns of their own as cases of coronavirus continue to rise. Dennis Otieno reports.
The East African nation confirmed its first case Saturday afternoon. The confirmed case is a 36-year-old Ugandan male who arrived in the country Saturday aboard an Ethiopian airline at 2 in the morning. Ugandan President Yoweri Museveni has since tightened preventive measures, which includes closing of airspace for passenger traffic.
To prohibit all incoming passengers, whether by air, land or water. In order to actualize this, we have decided to prohibit all passenger planes coming from outside Uganda from landing at any of the airports of Uganda. Only cargo planes will be allowed to fly into and out of Uganda. Also to be allowed in planes on account of emergency.
Rwanda has also imposed similar measures to stop the spread of COVID-19. The measures include lockdown in homes unless for essential services such as healthcare, border closure, restricting transport between cities unless for essential services such as transportation of food, and adoption of e-payments. Angola and Eritrea have also confirmed their first cases of coronavirus. 2 male residents who flew back from Portugal on March 17th tested positive in Angola, while Eritrea said its first case was a 39-year-old national who had arrived from Norway. Dennis Otieno, Citizen TV.
Care now, and also part of preventing the spread means that we must have all the information, then we can actually get the other teams to do their job. To all South Africans, please help us to protect you and your loved one. We need you to play your part. Government has put all these measures in place, but we need commitment of citizens to comply with this. Our position is now clear. We request that you comply. If there is resistance, we therefore need to enforce the resistance through the law. As already mentioned above, for us to minimize the spread, we must be able to identify the contacts of all the people who have tested positive for COVID-19. This therefore means once you are confirmed as a case, we will contact you and request you to avail a full list of people you have come into contact with 2 days from the onset of the symptoms. Simply put, if you started experiencing symptoms on Wednesday, you must disclose people that you came to contact with on Monday up to the date that you are informed about your positive results. It allows us to close the loop so that we find out who could still be at risk. Many of them may not be really high risk, but we will have to make that analysis and make the call. The form that a patient who has tested positive is required to complete is called the COVID-19 contact line list. Out of that, the people who analyze will then go through them and check what was the level of contact. The tracing team will then make the contact with those contact people, both physically and digitally. Some will be phoned, some will be visited, so that they are officially and be informed that they are officially contacts that have tested positive. They will then be taken through the screening and testing process. I'm aware that there is a strong debate about whether government can disclose another patient's information to his or her contact. Whilst we know that there is an ethical obligation not to disclose patient information with this outbreak, we will exercise Regulation 18, which stated that the information concerning a case, contact, or a carrier of the virus may be disclosed for the purpose of the public health surveillance, investigation, and intervention. This therefore means that if a confirmed case refuses to provide us with information, we'll go to the extent of making a public announcement that anyone that has come into contact with a specific person, disclosing their name, must present themselves to the public. In other words, if we ask you to go to quarantine, please go to quarantine. If you don't go to quarantine, we'll then enforce it. Again, if we ask you to give us a contact list, please give us a contact list. If you don't do it, we'll then enforce it. This is where the extent to which we have gone in dealing with this outbreak. We are then pleased, as I've said earlier, that there are, of those who have tested positive, 5 have already negative, and we are really expecting more and more will be getting negative. And I think for some reason we really are not seeing very severe cases, as it were. So the point I wanted to just raise is that we will later on make a direct announcement and call those people who are part of this church gathering in the Free State that we cannot find. We're going to check how many more we've been able to identify. Those that are missing, we're going to now make a public announcement that the people who are part of this church gathering need to come forward. We'll give them numbers which to phone so that they must come forward and be tested. Our concern about it is that of those that we have found in the church, we have found a number who were positive, but in addition, we are aware that people have moved and spread to different parts of the country. For that reason, it means that they may well be coming into contact with people and might be potentially posing a risk of them being infected. This means, therefore, that in that context, we want to try and contain that situation. Otherwise, we still want to encourage people. Now there's a flu season coming. We will be encouraging particularly those elderly to have the flu vaccines, and also those who have underlying illnesses to have the flu vaccines, just to make sure we limit the impact of the influenza. And then, of course, we will also be increasing our testing capacity. We are going to be getting over a lot of hitches that we're going through right now, and that at some point we would want to target the areas where we've identified contacts so that we can check if there would have been any significant spread at that level. It's still encouraging to see that we don't have many who are internal transmission, but that out of our process, once we freeze literally everyone in this kind of package, we are then able to go to the areas where, particularly highly densely populated areas, so that we are able to help to check the prevalence of the infection. That we'll be doing in the next few weeks. Obviously, some of the hitches on the delays relate to the fact that supplies will be affected by the changes in the flight schedules. So we'll be dealing with that, and myself and my colleague, Minister Patel, are going to be meeting up with the manufacturers of pharmaceutical products and those who are involved in supplying of health products, so that we can see what mechanism we have to expedite the supplies so that we don't run into shortages. Yes, now I've got the dates. The church name in the Free State is called the Divine Restoration Church Ministries. And they had a conference on the 9th to the 14th of March 2020 in Bloemfontein in the past few weeks, 9th to the 14th. Would like to request all those who have been part of that gathering to come forth, contact the Ministry of Health, the Department of Health in the Free State, so that they can be assisted. We can therefore go through the processing to look at their own situation, test them, and also just check if there are other people who need to be given attention to. We do want to make this as a public call, and it is important for us to make this. And I may as well say that the regulations actually do allow us at a certain point, if an individual does not come forth and has been a contact, and we think that his situation might pose a risk of infection to other people, we can actually publish the name to say those who have come into contact with this individual, either contact him to come over to us, or they themselves must actually make themselves available. We really want to leave no stone unturned to be able to deal with this issue of reducing the spread of the infection. At that point, Minister, I want to say thank you very much. I hope that it does clarify. Thank you.
Thank you, Minister Zweli Mkhize. We will now, maybe before we take our colleagues so that they tell us how they are going to implement the measures that the President spoke to yesterday from the economic cluster, because the Minister of Health will be leaving in no time. There is a meeting of traditional leaders that he has to attend. Now, if you allow me, colleagues, let's just take questions that are directed to the Minister before we start, so that we conclude that and we allow the Minister to leave, because the meeting is now at 11 o'clock. I hope I've got your permission to do so. Now, we will take questions on what the Minister of Health has spoken to in this press briefing. And again, we won't take many. We will take a few. 1, 2, 3, 4, 5. Thank you. That's quite good. Thank you very much. Let's start.
Minister Mkhize, please, how was the quick action by South Africa on the lockdown announced last night by the President, following the lead of China, who is now into recovery as a result of their actions and their economy is starting to open up? Can we learn something from their methods? And a question that relates to what was said last night, tens of thousands and then hundreds of thousands. We need hardware and we need respirators, because what we have in our private hospitals and our government hospitals will be an inadequate supply of respirators. Are we reaching out to our partners for help and assistance, as in China's coming out of it? Have we approached China for help? They're helping South Korea. Cuba is helping Italy. Do we know who's going to help us? Because that would be an encouragement to know that we are not standing alone with the shortage of hardware. I think that frightens a lot of people.
Thank you. Next.
Good morning, Minister. This is Christian Duplessis from Network 24. Minister, just how long could this outbreak last? Could it last longer than the 3 weeks that was proposed by the President? And then also, does healthcare workers have all the necessary equipment, respirators, to deal with the virus in the coming weeks?
Number 3.
Karabule Hlahle, CNBC Africa. I'd just like to ask the Minister when he expects that our curve, our infection curve, could possibly start flattening. Does he have a date or a period in mind? And also, we have heard of RH Bophelo, which is a black-owned medical company, offering its facilities to government should need be. I'd just like to know whether the other private healthcare providers do it. Thank you.
Next.
Minister Itekani here from Newsroom Africa. I just want to know how many people that have tested positive that are in hospital are currently in ICU.
Good morning, Criselda Lewis from SABC Television News. Minister, I'd like to know if there's any concern from government at this stage. This 24-hour period before we have the lockdown officially start, there might be some people moving from urban areas to rural areas during this time, and we're already monitoring and seeing that there's a lot of panic buying that is taking place. The queues are absolutely huge. And also, are you getting some help or sharing information with other international countries, for example, China with that experience and Cuba who is assisting in Italy? Thank you.
Today is our healthcare infrastructure and the preparedness activities that are happening across the nation in facilities and healthcare systems like Johns Hopkins Medicine, to prepare and make sure that we are as ready as we can be to safely care for patients who become infected with this novel coronavirus. At the beginning, I would like to just remind you that we have faced a number of infectious disease threats over the past several years. And the good news about that is that we learn more every time. We become more and more prepared. And I would like to point to the importance of the periods in between infectious disease threats and how building infrastructure and preparedness is critical for our ability as a healthcare system across the nation to respond to this kind of a novel pathogen, particularly pandemic respiratory virus. In particular, there has been a large investment in emergency preparedness infrastructure in this country that began with the Ebola crisis in 2014 and 15 in West Africa, and the Assistant Secretary for Preparedness and Response regional approach to making sure that we have treatment centers for patients with highly infectious diseases and a whole network of regional treatment centers and assessment hospitals and frontline care facilities. So really that the emphasis is that all parts of our healthcare system maintain readiness and an all hazards approach. That funding was really directed at viral hemorrhagic fever. But the great news is that it has allowed infrastructure to grow, partnerships to develop between the healthcare infrastructure on the front lines and public health authorities and all aspects of emergency management and preparedness. And I think that that level of preparedness has really allowed us to pivot more rapidly to be prepared to meet this threat. That doesn't mean, however, that we don't have a lot of work remaining to be done, because certainly we do. I will say that every institution has some manner of pandemic respiratory virus planning. We need to take those out, and hopefully everyone has already done that. Certainly at Johns Hopkins Medicine we have. Dust off those plans and think about really the nitty-gritty of what it will take to operationalize and implement those plans. Inevitably, one finds that there are novel aspects of the pathogen that must be addressed in applying those preparedness plans to the specific situation. And also moving forward and making sure that all of the myriad details are in place that might not be contained in such a plan. So we have heard from some of the other speakers about mode of transmission, which is a major piece that plays into preparedness. And so I would say that most of the pandemic respiratory virus planning in this country and probably around the world has centered on the assumption that such a virus would be spread by the droplet route, by really larger droplets that are expelled when a patient infected with a virus coughs and sneezes. Those particles tend to go about 6 feet in front of that person and then fall because they're relatively heavy and they land on surfaces and the floor. That's why it's so important to use environmental disinfection of high-touch surfaces as one of our strategies. However, there's another category called airborne transmission, whereby smaller viral particles, or droplet nuclei, they're called, really remain aloft for a longer period of time so that they can float around in the air and be inhaled by someone who comes along a bit later, even after the patient may have left the room. So that's a different kind of threat that we're used to handling in healthcare environments with tuberculosis and varicella and other kinds of pathogens. So there is a notion that this virus, although most of the data suggests that it's spread by the droplet route, that it is possible that the airborne route may also play a role, especially in certain circumstances where procedures are being performed in the healthcare settings, like intubation of a patient who needs mechanical ventilation, for instance, that may cause those aerosols to be present. So out of an abundance of caution, the current guidance from the Centers for Disease Control and Prevention is to use airborne precautions for this virus. And so part of the work that is being done in healthcare facilities across the nation and around the world is to try to figure out how best to take that pandemic respiratory virus planning and adapt it for airborne pathogens. That means several things. It means that we need to look, and we all are looking, at our facilities and the air handling in those facilities to determine critical planning for patient placement and then staffing to go with the patient placement so that we can provide the safest care possible in our facilities. We all have airborne isolation rooms, as they are called, that have special air handling for treating patients who have tuberculosis, varicella, measles, et cetera. But what we don't have is a large number of those rooms. And so many facilities, and Johns Hopkins Medicine is certainly leading this effort to look at air handling modifications that can be made to turn entire medical units in acute care hospitals into a respiratory isolation unit. We are also working really around the clock about how to ready ourselves to handle an influx of patients and a surge. We call that surge capacity planning. Many of our hospitals across the nation operate in a very lean sort of way, meaning that much of our healthcare delivery has been moved into the outpatient or ambulatory setting. So looking at the remaining inpatient acute care facilities that have really been streamlined for cost control, which is entirely appropriate. Now we need to ask ourselves how we can ensure that we have the staffing and the readiness in case a large number of patients do need inpatient care all at the same time, particularly if they need critical care services and mechanical ventilation, et cetera. So that's a lot of the work that's going on. And even when we find that the places for patients to be housed and the right air handling conditions, then staffing is another major concern. And we are working with our human resources colleagues and with our planners to make sure that we have the providers, the nurses, the respiratory therapist, and really every member of the healthcare delivery team ready so that we can ensure that we can provide care to all who need it. I wanted to take a minute and kind of walk through a couple of aspects of really how a patient might move through the healthcare setting, because it has implications really across the healthcare spectrum. As Dr. Inglesby alluded to, patients will have a wide spectrum of symptoms. They may be asymptomatic. They may have very mild disease, indistinguishable from a common cold or a shortness of breath that doesn't really progress. One of our tasks right now is to make sure that we get the right care to the right patient at the right time. And that means keeping the worried well and the mildly ill out of our emergency departments and our clinics, where they might not need to be, and they might cause exposures to other people who are there for other medical reasons, and also kind of clog the system. And so we have services that provide in-home care, colleagues. We also have opportunities to use strategies like telemedicine and phone triage to support patients who are recovering at home, and really encourage patients who are worried that they may have the virus but have very mild or no symptoms to recover at home. Turning then to those who present for care, testing is an enormous concern on our mind right now. As has been mentioned already, we need the ability to test rapidly. We need that to be at scale so that we can do widespread testing. I think you've heard today some reasons why we need that, to understand the epidemiology of what's happening in this country, but also for any given patient to decide on appropriate therapies and to get them immediately into appropriate isolation precautions. So that is a major amount of work that's going on. A word about supply chain. This is of concern across the healthcare system and something that our supply chain colleagues are helping us tackle to make sure that we have all kinds of options on the table about personal protective equipment, which is, of course, top of mind to keep our healthcare workers safe. But in addition to personal protective equipment, having a large amount of manufacturing in China that has in many cases been disrupted has led to allocation or suggested caps or enforced caps on over 400 items across all kinds of categories that we use in healthcare. So I think we have some strategies to deal with this, but this is one of the challenges that we are tackling. And I'll mention just a couple more things and turn it on to my colleagues. But partnership with federal and state health authorities is critical. And the more we can all work together, the stronger we will be able to respond to the needs that may come our way. And what would this look like? It might look like regional strategies for patient placement and staffing and a lot of the things I've described. So that it's not health systems like ours planning on our own, but really partnering with other health systems and federal and state and local public health authorities. I think we need to be mindful of accessibility issues and affordability issues that will be very important for patients, especially those who live far and have affordability challenges. And then finally, I just want to mention that we are also preparing to participate in clinical trials. You've already heard here today we don't have a vaccine, we don't have therapies, but we do have some candidate therapies, and it will be important to learn more about that and to make sure that we are offering the very best care at any given time, and meanwhile collecting data so that we can learn how better to handle this disease. Thank you.
Dr. Maragakis. I'll hand it over now to Jason Farley. Dr. Farley.
Good afternoon. I'm Jason Farley, professor at Johns Hopkins University School of Nursing. I would like to begin by thanking our frontline healthcare workers who are on the forefront of COVID-19 response. I thank you for what you're doing and the work that you've done, continue to do on a daily basis, as well as our public health officials for keeping us all informed and up to date as this outbreak occurs. I'd also like to thank each of you who are here today and supporting the members and